Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to talk a little bit more about case selection and treatment planning for sequential distalization cases. I wrote an Invisalign, could be ClearCorrect, could be Spark, I really don't care. Any company that allows you to have those longer treatment plans, not a company that caps you at 30 or 40 or 50 aligners. Whenever you're doing sequential distalization, you're in for the long haul. You're looking at a year to a year and a half to a 2-year treatment plan. Why is sequential distalization, I can't say that word, awesome? Well, it's awesome because you don't have to cut teeth. You don't risk pushing teeth through the bone transversely. You don't risk pushing teeth through the bone anteriorly. Basically, you're just using that hidden space that's just already there from having third molars out to straighten teeth. Oh, and you don't have to pull premolars, and you don't have to pull a lower incisor. So it's a win-win-win-win-win. But it's a matter of case selection. So you can't always do it. And I'm not saying I'm new at it. I've seen hundreds of cases, but I'm still learning like what works, what doesn't work. And just remember, most of the time, the crown tips back first, then the root uprights, as long as you're not doing it too fast. I've also learned that if you have a pretty traumatic third molar extraction and you don't give it a little time for the bone to fill in, that it can tip more crown first and some weird things can happen. So I definitely kind of would like there to be at least a month or 2 or 3 for the bone to fill in a little bit before you start dragging that tooth into an empty space, because I've seen some strange things happen. So just because a third molar is out doesn't mean you can necessarily do it. You have to check the Pano, and you also have to check clinically, is there a retromolar space? And what is the limits? I generally am trying to do about 2 millimeters on the lower, only because lower teeth move a little slower because the bone's a little more dense for the most part. Uppers, I've seen 4, 5, 6 millimeters work just fine, assuming you're not banging into the tuberosity. So you got to take that Pano, you got to look clinically, you got to see a retromolar space. Something like this, great, no problem, we can do 2 millimeters here. Something like this, no problem, great, we can do 2 millimeters here. I don't know if you can see these, but that's not going to work. This is a second molar. That's not going to work, and that's probably not work because you're already in the ramus there. You know, it's not going to. You're going to just basically you're going to run into the into the tissue, and half that tooth is going to be covered. And if you go too fast, you're going to get a perio pocket. So you can't go too fast. This one's kind of an example too. There's a tuberosity right there. You can verify how much movement there is by looking at your TMT. There's definitely TMTs in Invisalign. There's definitely TMTs in ClearCorrect, like 1.5 distal, 1.6 distal. That's all really good as long as you have the space. So that's pretty much it. That's just the things I've learned about case selection and treatment planning. Like I said, there's like so little education around it just within the Invisalign portal. A lot of us are just kind of going along and doing it. And remember, everything you learn with clear aligners is really extracted from braces. Yeah, we used to use appliances like distal jets and things like that and jumpers to distalize molars, and it was like a total mousetrap, and it just was super uncomfortable. It had all these weird springs and levers and stuff like that, cut up the patient's mouth, but we do it, and we would distalize those molars first, then we would use like a lingual arch for anchorage, and then we drag everything else against it. And it's the same concept as like TADs, throwing a TAD in there and then pulling things back. So, but this is non-surgical. So why have to do a surgery that's really painful and risky if you don't have to? That's my theory, right? All right, thanks so much.